Hello, my name is Dr. Anne Cruikshank, and this presentation will cover the diagnosis and treatment of Lyme disease. Lyme disease is an infectious disease caused by the bacteria Borrelia burgdorferi, which is a spirochete. It's transmitted by the bite of an infected tick and is the most common tick-borne disease in Europe and North America. There are multiple genus species which are responsible for the different clinical presentations, such as Lyme arthritis in the USA, more commonly in Europe and Asia, on neurological and skin presentations. The bacteria is able to spread quickly around the body, attracted to collagen-rich tissues, and is able to hide from and disrupt the immune system. The symptoms of Lyme disease were recognized in mainland Europe for over 100 years, but the correlation with tick bites was not clear. In 1975 in Old Lyme, Connecticut, a cluster of children were diagnosed with juvenile rheumatoid arthritis, which was subsequently found to be due to a tick-borne infection, initially named Lyme arthritis and then Lyme disease. It was first reported in England and Wales in the 1980s and has been described as the new great imitator, and that's in comparison with syphilis, another spirochete, which was previously referred to as the great imitator. The annual incidence worldwide is unclear due to no standardized data collection methods, but in the USA there are thought to be about almost 500,000 cases a year. France and Germany each have about 50,000 new cases. UKHSA data suggests only 3,000 a year in the UK, but it is not a notifiable disease, and the true incidence is known to be underestimated. Global seroprevalence is estimated at around 14.5%, and in Scotland itself, this was estimated to be an average 4.2%. There's no available data for the UK. In terms of the age range, people of any age can be infected. There seems to be an increased incidence in children between the ages of about 6 and 10, and also in an older age group between about 40 and 65. Ticks themselves are small blood-sucking arthropods. They don't jump or fly. They're found in moist, shady areas such as woods, heathland, moorland, long grass, even parks and gardens. And they remain attached to vegetation and wait for animals or humans to brush by. The ticks themselves can vary in size from the very tiny larvae and nymphs to the adult ticks, and at each stage of their life cycle they require one blood meal. This might be either via birds, small mammals, or larger mammals. Ticks are known to be present across the UK, with evidence of higher incidence in Scotland and the south of England, also Norfolk. The nymph ticks are tiny, the size of a poppy seed. Their bites are painless due to the fact that they inject local anaesthetic, and so they can easily go unnoticed. There's no proven minimum time needed for transmission of infection, but the longer the tick is attached, the greater the risk. The infection rate amongst ticks is thought to be on average about 4 to 5%, and it's known that they can carry other pathogens, such as anaplasma, babesia, rickettsia, and tick-borne encephalitis. Adults seem to be mainly bitten on the legs and arms. Children, it's been noted, seem to be more likely bitten above the waist, particularly around the neck, the hairline, behind the ears. So ticks, if possible, focus on moist protected areas and can remain attached for several days if undisturbed. And traumatic removal of the tick increases the risk of transmission of infection. The nymph or larvae ticks will remain small even after having been attached for several days. So tick bite prevention is key, and the advice is to wear long sleeves, tuck trousers into socks, wear lighter coloured clothing if possible, use insect repellent, avoid long grass, carry a tick removal tool, carry out tick checks during and after being outdoors, remembering to check children and pets, remove any attached ticks carefully, and know the signs and symptoms of Lyme disease. A recent online survey by the Lyme Resource Centre demonstrated that of people who became infected, more than 50% had not been aware of the need to avoid tick bites or of the signs and symptoms of Lyme disease. Many also didn't even recall having been bitten. So the Lyme Resource Centre is focused on tick bite prevention across all age groups, including schools and colleges and outdoor organisations such as Duke of Edinburgh Scouts and Guides. And more information is available on the website. In terms of removing a tick, it's important to remove it carefully as soon as possible. Ideally, use a tick removal device such as a tick card, tick twister, or fine tip tweezers. Avoid traumatizing the tick, so don't cover it in gels or oil, or burn it with a cigarette, or squeeze the body of the tick when removing it. In terms of managing tick bites, it's important to ideally record the date and location of the tick exposure or the tick bite, the site of the bite, how long the tick was probably attached. Look for any signs of rashes or flu-like symptoms at that time or in the weeks and months following. Understand the possible risk of Lyme disease and seek medical advice if symptoms develop. Testing isn't normally indicated if there are no symptoms. It may be unreliable in the first few months after being bitten, and prophylactic treatment is not usually indicated. If a person develops symptoms, it's important to access antibiotic treatment as soon as possible. Further information includes seeking advice on how to avoid tick bites in the future, and the Lyme disease charities and UKHSA provide a lot of information in this area. Lyme disease itself is described as having different stages. The early localized Lyme disease occurs in the days or weeks after the infection. Early disseminated Lyme disease in the weeks or months after infection, and late disseminated disease may occur months or years after the tick bite, when the tick bite is long forgotten. 10 to 20% of cases do develop persistent symptoms following antibiotic treatment. This is well recognised. This is often referred to as post-treatment Lyme disease or chronic Lyme disease. The exact cause is unclear. So the symptoms of early Lyme disease may include the Erythema migrans rash, which is diagnostic of Lyme disease, or non-specific flu-like symptoms such as fever, fatigue, headache, neck ache, muscle or joint aches. But barriers to diagnosis may include the fact that a tick bite is not noted, the EM rash may be atypical, or the symptoms may even be attributed to a viral infection or summer flu. The Erythema migrans rash usually occurs 3 to 30 days after the tick bite, but is absent in 30%. It's usually an expanding red rash, but not necessarily a bullseye. Usually painless, not usually hot or itchy, but it might be atypical, affecting multiple sites, variations in colour or an irregular shape. It can easily be misdiagnosed as another insect bite, an allergic reaction, ringworm or cellulitis. So a detailed history is key. And resolution of the rash does not mean that the infection has resolved. Antibiotics will still be required. These are several images from the NICE Guideline. You can see the variation in size and features of the rashes. And these may occur at multiple sites across the body, not necessarily at the site of the bite. Early disseminated Lyme disease can vary in presentation. There may be the general symptoms, plus or minus the EM rash. There may be cardiac symptoms or neurological symptoms. One of these to note particularly is facial palsy, which may occur at a very early stage when no other symptoms may be present and easily misdiagnosed as a Bell's palsy. And these types of symptoms may occur in the days or weeks after becoming infected, and it may take a detailed history to establish the possibility of tick exposure. Disseminated disease can occur quickly or may take weeks or months. And again, some of these symptoms which may occur at an early stage may also first present at a later stage, Facial palsy in particular can be an early or late manifestation. Other neurological symptoms, cardiac symptoms, skin or musculoskeletal symptoms, psychiatric or psychological symptoms, and other general symptoms may all present at different stages, with the patient presenting with multisystemic, fluctuating, and often migrating symptoms. Paediatric Lyme disease may be challenging to diagnose if symptoms are non-specific and difficult to assess. Again, it will cause flu-like illnesses, fatigue, facial palsy, other neurological symptoms, headaches, fevers, behavioural changes. Some recent research into the issue of facial nerve palsy has concluded that in areas endemic with Lyme disease should be considered as the likely cause of facial nerve palsy in children until proven otherwise. It is, of course, important to remember that children, even if not living in endemic areas, may well visit these areas. So Lyme disease should always be considered in children with facial palsy. As described previously, Lyme disease can imitate many other conditions, such as Bell's palsy, MS, motor neuron disease, Guillain-Barré syndrome. Patients are sometimes even diagnosed with functional neurological disorders. Cardiac causes such as pericarditis and myocarditis, musculoskeletal, dermatological, psychiatric illnesses, or general illnesses including ME, CFS, irritable bowel syndrome, B12 deficiency. And these symptoms again may be multisystemic, fluctuating and migratory, and a patient may gradually be acquiring more and more different diagnoses, which are in fact all due to the same infection. With the new pathway of pharmacy first, many patients with insect bites will now be presenting first to pharmacists, and it's important to be aware that EM rashes and insect bites may be very difficult to differentiate from each other. This chart was devised in order to help assess the difference between an allergic reaction and an infection, or an EM rash. Ringworm can also often have an appearance similar to a bullseye rash. The key issue is probably that a tick bite is painless, so any painful insect bite will be unlikely to be a tick bite. And this pathway was devised to try to help pharmacists look at that possibility. One of the first questions to ask may be, does the person remember an insect bite? If yes, then it's logical to follow through with the pharmacy first pathway. If no, then the possibility of Lyme disease needs to be considered. Testing is not required if an EM rash is present. It's important to use clinical presentations as well as testing to guide the diagnosis, and to remember that blood tests can be unreliable and that a negative test result does not exclude the diagnosis. There's also no test of cure. Testing is done via a 2-tier immune-based test, which can be requested by the GP or within secondary care. The initial test, the ELISA, is done either locally or at the Lyme laboratory. If this is equivocal or positive, or if the patient has had symptoms for more than 12 weeks, then an immunoblot should then be carried out. This is done at the Lyme lab at Porton Down. Interpreting the results can be challenging. It can be worth discussing with the Lyme reference laboratory, and remembering again that a negative test does not exclude the diagnosis. This would be the standard rippled request form, which can be found online. The consultants at Porton Down do emphasise the importance of providing as much clinical information as possible to help in interpretation of the results. Results may then come back to a GP in the following formats, either as a list of immunoband blots or as a summarised positive or negative result. It's important looking at this result here where the IgM was negative but the IgG was positive. This was interpreted by a clinician as indicating past infection, even though the patient had never been treated, and the patient was refused treatment despite the fact that this clearly needed to be actioned. The NICE guideline was developed in 2018. The key points around diagnosis are that patients should be diagnosed and treated if an EM rash is present, and the diagnosis of Lyme disease should not be ruled out if the test is negative but there's a high clinical suspicion of Lyme disease. Children and young people cases should be discussed with a specialist if there's more than just a single EM rash. Key points around treatment are that early antibiotic treatment increases the chance of complete recovery. Dosages are higher and of longer duration than other conditions. If there's a clinical suspicion of Lyme disease without an EM rash, then treatment should be started even whilst waiting for results. And if symptoms persist after the first course of treatment, a further 3 weeks of a different antibiotic can be given. Patients should be warned about the Yerkes-Herxheimer reaction, which tends to often be an exacerbation of pre-existing symptoms, but must be differentiated from an allergic reaction. If symptoms are ongoing, it's important to consider treatment failure, reinfection, organ damage, other possible diagnoses, and consider referral to secondary care. The NICE Guideline Committee acknowledges the limitations of the guidelines due to the limited epidemiological data within the UK and the poor quality evidence available on diagnosis and treatment. The recommendations aim to standardise antibiotic treatment, but there is certainly a need for further development of further diagnostic testing and treatment regimes. Mother-to-baby transmission of Lyme disease is noted to be possible in theory. So in summary, the NICE guidelines, EM rash is diagnostic and no test is required. Doctors can treat based on clinical suspicion. A 21-day treatment course should be followed by a second course if symptoms persist, and a negative test doesn't exclude the diagnosis. There's a limited evidence base for the guideline and more research is required. Unfortunately, there are no specialist Lyme disease clinics within the UK and no safety net for patients with persistent symptoms. The treatment guidelines are complex, difficult to remember, and certainly a clinician should refer directly to the NICE guideline when treating. First line treatment in adults would be doxycycline for 21 days. Second line would be amoxicillin or azithromycin. CNS and cardiac symptoms may require intravenous ceftriaxone. In children aged 9 to 12, doxycycline is still first line. Under 9 years, amoxicillin would be first line, but it's important to note that this is of high dose, 30 milligrams per kilogram for 21 days. Again, it's important to remember that early and adequate treatment gives the best chance of cure and that a second course of treatment may be indicated. There is a BMJ visual summary of these antibiotic guidelines, which people may find helpful. It's important to be aware that prescribing errors in relation to dosage and length of treatment seem to occur in both primary and secondary care. The Lyme Resource Centre Lyme Disease Experience Survey looked at compliance with the NICE guideline, and based on 100 respondents who were diagnosed following publication of the NICE guideline, 50 people reported having had a blood test despite having an EM rash, and antibiotic courses were often delayed or inadequate. 30 people with ongoing symptoms did not receive a second course of antibiotics, and 73 of the 99 respondents reported that they had not yet fully recovered. There are other Lyme disease guidelines. The International Lyme and Associated Diseases Society, ILADS, recommends 4 to 6 weeks of antibiotics for an EM rash, advises treating until all symptoms resolve, and retreating if symptoms recur. Other European guidelines acknowledge the key areas of uncertainty and recommend the recommendations for further research. There's certainly no international consensus on diagnosis or treatment. It's acknowledged that 10 to 20% of patients continue to have persistent or recurrent symptoms after 2 to 4 weeks of antibiotic treatment. The cause of this is not entirely clear, but even patients treated at an early stage with apparently adequate treatment still in 14% of cases, patients reported ongoing symptoms. Johns Hopkins Lyme Disease Research Centre has identified a subset of patients who remain significantly unwell 6 months after following standard antibiotic treatment. And these were characterised by a constellation of symptoms, including fever, musculoskeletal pains, sleep disturbance, depression, and cognitive problems. And they are investigating the potential roles of infection-induced immune dysfunction, chronic inflammation, persistent infection, neural network alterations, other tick-borne infections, and other biological mechanisms of disease. So the issue here is certainly that the possibility of ongoing infection has not been excluded, and this is an area of ongoing uncertainty. The LRC Lyme Disease Experience Survey actually found very similar findings amongst the patients reporting ongoing symptoms, with fatigue being the most common, impaired thinking, joint pains, muscle aches, and impaired sleep, anxiety, neurological symptoms. So in summary, the key issues are that this is a complex multisystemic disease which can be difficult to diagnose. Testing may be unreliable. Early and adequate treatment provides the best chance of full recovery, and there's no international consensus on diagnosis and treatment. And this really is a very genuine scientific uncertainty. It's important to remember that tick bites often go unnoticed, that an EM rash is diagnostic of Lyme disease but may be absent or atypical. In people with unusual multisystemic symptoms, consider the possibility of Lyme disease and take the relevant history. And it's important for other diagnoses to obviously be excluded. The role of primary care is really to raise public awareness of ticks and Lyme disease, provide early diagnosis and treatment, accurately read code, which is important since this is not a notifiable disease, recognise the symptoms of late Lyme disease, be aware of the scientific uncertainties, and provide patient support. This final slide provides links to a range of relevant websites. The RCGP Lyme Disease Toolkit is open access and has recently been updated, available for health professionals and the general public. The RCGP e-learning module is freely available to all health professionals. The NICE, CKS and UKHSA websites all provide important advice and information. There are 3 Lyme Disease UK-based charities, the Lyme Resource Centre, Lyme Disease UK, and Lyme Disease Action. All provide a range of information and resources such as posters, leaflets, and evidence-based information. Thank you for listening.